Let's talk about the topic Sacrocolpopexy from Talinde's 12th editions. Uh, the concept of reinforcing a surgical repair of pelvic organ prolapse with surgical mesh permeates the gynecology literature. The procedure of sacrocolpopexy utilizes a suspensory brace of either biological or synthetic material attached to the anterior sacral ligament. Suspensory brace either biological, or you can use a biological or a synthetic material that will attach to the anterior sacral ligament, anterior longitudinal ligament, that will reinforce the normal apical support. The sacrocolpopexy the sacrocolpopexy was originally described as a treatment of post-hysterectomy pelvic organ prolapse. The sacrocolpopexy prevent recurrent pelvic organ prolapse rather than a treatment of recurrent pelvic organ prolapse rather than as a treatment for recurrent pelvic organ prolapse. The sacrocolpopexy is prevent recurrent prolapse but rather than a treatment. This is a new approach, other approach you can use. What are the preoperative considerations? The goal of surgical repair of pelvic organ prolapse is alleviate the patient's symptoms. This is accomplished through structural changes to the anatomy. Maximize the normal bladder and bowel coital function is based achieved through this pursuing normal listen. The care should be taken to avoid overcorrection. Like you should not do overcorrection so that make the anatomy distorted. If you tie so tightly the mesh, then that will straighten the uretrovesical angle and that lead to over incontinence. Many patients with apical prolapse have other support defect that should be treated simultaneously, and this should be a part of the consideration in surgical planning. Some women with apical prolapse also have symptoms of stress urinary incontinence. The surgical treatment of SUI may be performed at the same time of sacrocolpopexy. In addition, some women with severe prolapse who don't have SUI may risk to develop SUI after surgical correction of prolapse. So this phenomenon is called as awkward stress incontinence. The use of surgical mesh should be discussed with the patient as part of surgical consent. Consideration of patient functional goal. Risk factor for recurrence you have to explain. The risk factor of surgical complication has to explain. Preoperative bowel aspiration is not indicated by either laparotomy or minimally invasive approach. However, the antibiotic prophylaxis and second generation cephalosporins can be recommended. Thromboembolic prophylaxis is also recommended in the form of sequential decompression stocking or injectable anticoagulant. If Foley's catheters, a patient should be placed in dorsal lithotomy position with leg in Allen stirrup, a Foley's catheter should be placed during the surgery to drain the bladder. As for all surgical cases, a surgical safety checklist should be completed prior to the beginning of surgery. What are the steps in the procedure of sacrocolpopexy? The patient should be positioned in aligned stirrup. Antibiotic thromboprophylaxis are initiated. Surgical safety checklist should be completed. Bladder is drained with an endoling Foley's catheter. Pharyngeal incision is created. Peritoneal cavity is entered. A self-retaining retractor is placed. Abdominal content are packed out of the pelvis. Presacral space is entered through a longitudinal peritoneal incision. Above the, you have to give a peritoneal incision above the sacral promontory. The peritoneal incision then extended onto the cul-de-sac. You have to go up to the cul-de-sac, keeping the all the structure, the right ureter and rectum. The middle sacral vessels are should be identified. The ventral surface of the S1 S2 vertebral body are exposed. An end-to-end anastomosis sizure or stent can be placed in the vagina. These things has to be used to make the vagina straight and prominent. The rectovaginal septum is open. Rectum is separated from the vaginal wall. Vesicovaginal space is also open. Then next the vesicovaginal space is open. The bladder is separate, dissected from the vagina. A 3 to 4 centimeter wide and 14 centimeter, 3 to 4 centimeter wide 14 centimeter mesh. 3 to 4 centimeter wide and 40 centimeter long graft of polypropylene is attached to the rectovaginal septum using a rows of interrupted transverse suture of delayed absorbable monofilament suture. A similar graft is attached to the pubocervical fossa using similar technique. Some surgeons are doing Halban coltoplasty, maybe to obliterate the cauldus sac, that will prevent the bowel uh, enter into the prevent the exposure of the mesh to the bowel. The graft lies in the hollow of the sacrum, then stood in contact with the anterior sacral ligament without any tension. Without tension, two non-arterial suture are placed through the mesh anterior and through the mesh. Two non-arterial suture are placed through the mesh and the anterior sacral ligament with care to avoid injury to the middle sacral vessels. With sutures should be tied down. The vagina should be elevated without tension on the graft. Then you do a cystoscopy to evaluate the ureteral patency and to exclude any ureteral tract injury. The peritoneum is closed over the graft and the abdomen is closed in layer. Surgical technique: access to the peritoneal cavity. The access to the peritoneal cavity is possible through either phalangeal or longitudinal midline incision. The phalangeal incisions offer advantage for healing osmosis and usually provide adequate visualization. The patient is placed in tenderloin position. Self-retaining retractor is placed to facilitate the exposure of the sacral promontory and vaginal vault of uterus. A rigid self-retaining retractor is acceptable, but they usually prefer to a flexible circular wound protector or retractor, as it offers excellent visualization and quick, simple to place, and eliminate the risk of neuropathy associated with the rigid retractor. Once the retractor is in place, the bowel is backed away, the rectum segment colon retracted to the patient left, providing exposure to the peritoneum overlying the sacral promontory. Then dissection of the sacral promontory. The dissection of the sacral promontory offers the highest risk of hemorrhage because generally below the sacral promontory there will be middle sacral vessel. It will mostly the sacral promontory, the point where the bifurcation of the aorta is there. The external leg, right common leg vein, right ureter aortic bifurcation, and middle sacral artery and vein are there. So we should be very cautious to prevent injury during the dissection of the sacral promontory. The incising the peritoneum overlaying the promontory provide an entry into the retroperitoneal presacral space. The peritoneum overlaying the sacral promontory is grasped and elevated with forceps to allow a longitudinal incision to carry almost to the aortic bifurcation. The surgical goal is to clear up the promontory and expose the anterior sacral ligament. And the important structure to consider during the dissection: the middle artery and vein, intimal course along with the anterior surface and anterior sacral ligament. As well, you remember the hypogastric nerve plexus and lateral sacral venous plexus located within the overlying alveolar tissue. The plane between the anterior longitudinal ligament and nerve surface are usually developed using blunt dissection. You should do a blunt dissection to make a plane between the anterior longitudinal ligament and the vessels and nerve. But it's much easier to identify when enter into the upper sacral promontory. Gently elevating and separating the alveolar tissue permits safe identification of the middle sacral vessel, which can then be avoided when division of nervous tissue require cautery. It is wise to direct cautery instrument away from the bony prominence while cutting to avoid unplanned injury to the middle sacral vessel. You should avoid using cautery while near to the bony prominence because it can injure the middle sacral vessel. The dissection of the alveolar tissue continue to reveal the anterior sacral ligament down to the level of S3. This is the right ureter, this is the rectum has two separated, and the dissection of the vaginal vault, dissection of the opening, then dissection of the sacral promontory, dissection of the vaginal part. Once the presacral space is developed, the vaginal apex must dissected, allow attachment of the mesh. This require opening the dissection of the vesicovaginal and rectovaginal space in order to isolate the vaginal vault from the bladder and the rectum respectively. If the uterus is present, a hysterectomy is planned. This will be prior to the vaginal dissection. The vagina dissected free of the bladder anteriorly and the rectum posteriorly. At the beginning of the dissection, the rectovaginal space offer advantage for visualization, especially when pursuing endoscopic approach. Here the main important thing is traction and counter traction is a key principle in the dissection of the required vaginal stent. So to give a traction and counter traction, so that's the reason there will be a vaginal stent is required. By that is maybe end-to-end anastomosis. The stent may be an end-to-end anastomosis suture or basically Navaratri retractor, Navaratri placed in the vagina directed toward the anterior abdominal wall can serve this purpose of vaginal stent that will help in giving traction and counter traction. This vaginal strain will stretches the vaginal wall taut and and using a atraumatic force to pull the rectum in opposite direction, provide the counter traction that will help in the dissection of the rectovaginal septum properly. The dissection of the rectovaginal septum begins with the creation of a transverse incision in the peritoneum between the uterosacral ligament and the superior ligament of the superior anterior part of the cul-de-sac. The incision gives access to the superior aspect of the rectovaginal space, which is then developed toward the inferior aspect of the perineal body using blunt dissection, traction, or counter traction. A malleable retractor during laparotomy or bowel grasper during laparoscopy can use to develop the space bluntly. Like the rectovaginal space, the same thing you can do vesicovaginal development or vesicovaginal space depending on the traction, depends on the traction and counter traction. Then end-to-end anastomos suture, or you can use the Brisky Navaratli retractor which has been placed in the vagina. It's now directed toward the sacral promontory. The vaginal stent stretches the vaginal wall taut and while using a atraumatic gasper pull the bladder in the opposite direction, providing the counter traction. Sharp electrocautery dissection through the peritoneum of the vesicovaginal reflection between the bladder and the vagina open the vesicovaginal space. The space is then developed with blunt and sharp dissection. Bleeding with this pain usually comes from the detrusor muscle of the bladder, serve as useful to keep the dissection close to the vaginal wall. So to prevent decreased blood loss, so you always go towards the vagina, the dissection towards the vagina, prevent bleeding from the detrusor muscle. The dissection should be extended nearly as far as the bladder trigon. This is the end-to-end anastomizer suture. This acts as a stent. Rectovaginal space, vaginal vault, vaginal space opening, rectovaginal peritoneum, rectovaginal space. This is the mesh, 3 to 4 centimeter width and 14 centimeter length. Mesh attachment. The durability of the sacral promontory. The durability of sacrocolpopexy is generally attributed to the use of graft to reinforce the apical support of the vagina. Although this must be balanced by the fact that the graft is also add a foreign body with associated risk. Most notably, mesh exposure will be there. So a variety of synthetic material including polypropylene, polyethylene tetraphthalate, expanded polyethylene fluoroethylene has been used, as well as xenograft like porcine dermis, allograft like cadaveric skin or fasciolata. However, most surgeons now use 3 grafts composed of large pore soft weave polypropylene mesh, which has been shown to has the best balance between durability and complication. This also covering animals. 2 leaves of mesh are required. 2 leaves of mesh are required, should measure 3 to 4 centimeter width and 2 centimeter length. The first graft is attached to the rectovaginal fascia of the posterovaginal wall with transverse row of interrupted suture. During laparotomy, a malleable retractor in the space facilitates the suture placement by keeping the rectum out of the way. Some surgeon recommend that lateral suture should be incorporate the levator muscles while they meet the rectovaginal fascia. These sutures should be tied relatively loosely to avoid necrosis, which could predispose to postoperative expression. If you do necrosis, that will expose to the necrosis and may also erosion started. The second leaf is shown to pivot cervical fascia of the anterovaginal wall with rows of interrupted transverse suture with both anterior and posterior leaves. The goal is to have to mesh lay flat against the endopelvic fascia of the vaginal wall. Again, these sutures should tied relatively loosely to avoid necrosis that could predispose to mesh exposure. Many surgeons prefer non-observable monofilament suture, although you use a 2-0 delayed observable suture. Polytetrafluoroethyl suture should be avoided as there is a higher rate of exposure. Once the anterior and posterior mesh pieces are attached to the vagina, they may be attached to each other at the lateral aspect of the vaginal cuff to each other by creating a Y configuration. Many surgeons will perform a colpoplasty, close the cul-de-sac before completing sacrocolpopexy to prevent small bowel from prevent the small bowel get insinuating behind the graft. An example is the Halban colpoplasty. Other surgeon may get tunnel the mesh through the retroperitoneal tunnel to accomplish this. Finally, the mesh arms are sutured to the anterior sacral ligament. Mesh arms are sutured to the anterior. Use a non-observable 2-0 monofilament delayed observable suture. Be sure to that use a tapering needle. Don't use a cutting needle, otherwise it will injure to the middle sacral artery. These sutures should be placed at the S1 and S2 level The site reproduce the normal vaginal axis. Avoid high risk of bleeding S3 as per label. Surgeon may be attempted to the place suture at the promontory, but the site should be avoided. Promontory suture should be avoided because there will be a risk of associated complication like discitis and sacral osteomyelitis. Place the suture in the anterior sacral ligament carefully as the laceration of the medial sacral artery can result in rapid and difficult to control hemorrhage. We place the suture around the medial sacral artery embedded in the ligament as it is simplify the management of possible bleeding. So you can go for tying the medial sacral artery before putting this suture uh, around the anterior sacral ligament. That will prevent the bleeding to the medial sacral artery. You can tie beforehand. Upper opportunity to close the vessel when tied. Place the suture in the anterior sacral ligament carefully as the laceration of the middle sacral artery is rapid, difficult to control embrace. We place the suture under the middle sacral artery embedded in the ligament. The attaching mesh to the vagina, here polypropylene graft is attached to the anterior vagina. The vagina is destined by stent interrupted monofilament suture have been used to secure the graft. The right angle clamp elevate the graft toward the sacrum. Colpopexy is a series of intricate sutures placed in the running fashion, being distally in the posterior vaginal wall, then returning proximal to the ventral surface of the rectus segment. After all sutures are placed, they tie down and approximate the posterior vaginal to the rectus segment. Suturing the anterior sacral ligament, the placement of suture to enter the medial sacral artery. The proper tensioning is a key element for successful surgery, and the intervening mesh should lie loosely against the sacral hollow without tension with sufficient redundancy to accommodate contraction with mesh integration. It is also important that the mesh breathes tension free to prevent overstretching the uretrovesical angle that can lead to de novo incontinence worsening the pre-existing incontinence. If there is already a pre-existing incontinence, that will exacerbate if there excessive tension in the mesh, that will straightening the uretrovesical angle that will lead to development of incontinence. Many surgeons advise closing the peritoneum over the mesh in order to decrease the risk of small bowel obstruction. To prevent small bowel obstruction, you can do peritoneum closure over the mesh, which occur in 6% of sacrocolpopexy surgery. The running 30 observable suture injury to the bladder and uterine potential complication of resection repair. Consequently, intraoperative cystoscopy can involve the urethra, always recommended following completion of the repair. Sacrocolpopexy. Similar to the post-operative concern, most patients hospitalized for 1 to 2 days following surgery. Prolonged bladder drainage is not generally necessary for patients with normal bladder function, although indwelling catheter is appropriate until the patient is awake or overnight. Once the bladder catheter is removed, voiding trial may be performed to ensure normal bladder emptying. Post-operative plan management usually managed with regular scheduled non-steroidal anti-inflammatory drugs to ensure that patient is normal renal function. This helps to minimize the post-operative pain by providing baseline analgesia. Narcotic are administered intravenously. Generally, when patient anti-inflammatory narcotic, patient should be instructed to observe pelvic rest at least for 6 weeks until the incision has been fully healed. During the first 6 weeks, there should not be an increase in intra-abdominal pressure. Activity should be avoided to prevent refrigerations to recurrent prolapse. And over-the-counter stool softener can be used if they have a defecation, constipation. Multiple investigations show that sacrocolpopexy is durable surgery. Correction of vaginal wall prolapse with excellent result reported management. The complications of the surgery. Post-operative complications of sacrocolpopexy include gastrointestinal complications like paralytic idea, small bowel obstruction, wound complication, wound expected and niche procedure. Male aportomy, small bowel obstruction occur 6% of cases. Bowel ureter injury rare, less than 3 hemorrhages, especially pre-sacral vessels can be life-threatening. Hemostasis can be difficult because damaged pre-sacral vessel lead to retreat beneath the bony surface. Bony surface. Suture hemoclips bone wax can be used initially. If this measure fails, the sterile thumb tacker can be used. Most common long-term complication mesh exposure in the vagina. Medium-term massage is 3 to 4% mesh exposure. Symptomatic mesh exposure cause vaginal discharge, spotting. How will manage the mesh exposure? There will be complaint of vaginal discharge, spotting, dyspareunia, pelvic pain. Surgical management should begin with vaginal excision of the exposed mesh. You expose the mesh closer of the vaginal orifice edges Approximately 50% max exposure resolved by this technique. If unsuccessful after excising the mesh and closure of the vaginal ace, then you do a complete excision should be approached by laparotomy. Important, only 80% patient with max exposure successfully treated after mean major complications. Indication of sacrocolpopexy. Expert opinion that the most appropriate approach to manage apical prolapse. 3 randomized trial. The trial favored the sacrocolpopexy up to 29% of the post-operative stress in continuous. The result confirmation because of the dependent. Preferred treatment apical prolapse. Current controllers. Although exact indication of abdominal sacrocolpopexy are controversial, many surgeons use surgical recurrent prolapse, especially for cases of post-hysterectomy valve prolapse. In the early surgeon began to use patient felt at risk of recurrent valvular prolapse. Typical risk factor: those having young age at presentation and damaged pelvic floor muscles. Patient with condition as increased risk of intra-abdominal pressure. Those having increased intra-abdominal pressure, cough, chronic disease, and risk of pelvic floor damage, inverse presentation with damaged pelvic floor muscle or pelvic organ prolapse or apical prolapse or prevent recurrent prolapse. We tend to offer the patient with recurrent pelvic or abdomen with most severe prolapse or to young age prolapse with pelvic damage, highest risk of recurrence for the setting of damaged pelvic floor muscle. Some such key points reserve factor which is the treatment of recurrent prolapse. While other recommendations treat to severe prolapse in women who fail to have high risk of recurrence damaged pelvic floor muscle, younger presentation, or already have risk to develop like chronic cough, increase intra-abdominal pressure. Important landmark for the pre-sacral dissection include the aortic bifurcation, right middle, right common iliac vein, right ureter, middle sacral artery dissection of the rectovaginal vaginal space is more best accomplished with the vaginal stent, that is the end-to-end anastomosis seizure, such as to end-to-end anastomosis seizure or Brisky Bradley retractor in the vagina. For sacrocolpopexy, the prepared graft material is large pore soft wave polypropyl mesh. With this material, the risk of mesh exposure is 3 to 4%. Some studies high rate with the long-term follow-up. Proper tensioning will result graft lying loosely against the sacral wall without tension.